Okay. So hopefully you see the first slide there. So again, this is going to be a presentation on, I say all things female hormones, but really it's kind of between age 35 and really 60 and beyond. It's going to cover perimenopause and menopause. My name is Macaulay. If you don't know me already, I'm a physician assistant. I've been practicing since 2011. But I've been practicing functional medicine just for the last couple of years. And what functional medicine is, if you don't already know, is getting to the root cause of the illness. So I do kind of look at all things, although I also practice Western medicine, but through the lens of, you know, hold on, I'm just admitting a few more people, of not only getting to the root cause, but helping people to just live their optimal life and feel as best as they can in any stage of life. So that's a little bit about my background. I work at SeeBeyond Medicine, obviously in Scarsdale. And a lot of this is really applicable to our practice here because we do kind of all of the above. So I will just start jumping in. Okay. So I put a picture of Oprah here because probably some of you have been aware that Oprah and a couple other celebrities are bringing a lot of attention to perimenopause and menopause now, which is awesome. But I bring up Oprah specifically because she went through kind of what her symptoms had been, and it took Oprah Winfrey 5 different doctors and several years to get someone to talk to her about perimenopause. And that just really struck me because if it's taking Oprah, who has the means, both financially and access, she's a very well-known figure. She can get into any doctor anywhere. And she still really struggled to get a provider to talk to her about why might she be having symptoms? Why might she be having mood changes? Like, what's it going to be like for the rest of us? And so, I'll go through all of the details of the science and the data behind perimenopause and menopause. But I think if I could drive home one important thing, it's finding yourself a provider who's not only knowledgeable, but they'll find the answers if they don't have them, and who will really listen to you, because as women, we know our own bodies, and who will go through all of these options because it's different for everyone. And if Oprah struggled, she can't be the only one. So that's kind of why I bring up that point. And then the other one is that women are living longer. We're living fuller lives, which is amazing. At least a third of our lives now is going to be spent in menopause. So this isn't like a blip on the radar where we just have to power through some symptoms. This is really significant, life and quality of life altering. So I'll get into that in more detail. This is kind of what we're going to go over. And hold on, sorry. I bring up this slide because this is even when I went to school, this was the old thinking. We have the hypopituitary adrenal axis. The brain gets messages. It tells the ovaries and uterus to start producing hormones, and simple as that. So this is the approach that used to be taken when we're dealing with women's issues. This is what we know now is really happening. And you don't need to, memorize this, but the point is it's really complicated and there's a lot of patient variability. So all of these different pathways here, you can see your sugar levels matter, your inflammation matter. Of course, we are talking about your ovaries, your uterus, the effects of hormones through the body. But I did read something that I keep coming back to over and over as a provider. But when treating someone for perimenopause, menopause, or any sort of imbalance, you can't forget the GALS. So the GALS stands for gut, adrenals, liver, how well you detox, and sugar and sensitivity. What is your sugar balance? So again, the details of this aren't important, but just that it is complicated. It's complicated for me, and I work in this profession. So again, this is why there is so much conversation going on about perimenopause and menopause. And then I get this question a lot, why is hormone replacement therapy so controversial? Why is this subject so controversial to begin with? Most of that is to do with the Women's Health Initiative study that was almost 20 years ago. The study was actually supposed to look at, does HRT, hormone replacement therapy, prevent heart disease? It was abandoned before it was finished, and the results were inappropriately extrapolated to say that it caused breast cancer, which is not what the study was powered for. And I'll get into the actual data later. But the point is, there was a lot of information released that we now know not to be true. It does not cause a 25 or 26% increase in breast cancer. And it's been released that this is not really applicable to the hormone replacement we have now. But the sad thing is, a lot of providers changed their practice. And there's whole generations of women who weren't able to benefit from hormone replacement therapy due to just total fear of providers, doctors, PAs, nurse practitioners. We're just too afraid to even prescribe it. So overnight, there was a big shift in the medical landscape. All right, so now we're just going to get into the nuts and bolts here. So what is perimenopause? It's otherwise known as the menopausal transition. It's a pretty big, they say it can last up to 10 years. Usually it's between 4 and 8 years. Anywhere from age 35 to 50-ish, 55, is when you can start to go through it. Some people have a lot of symptoms. Some people have very few. In those last 2 years, right before menopause, is when the estrogen really does start to go down. So most people will be symptomatic then. But perimenopause, spans a pretty big period of a person's life. And usually the symptoms you have are related to progesterone. You probably haven't seen this graph since like 8th grade health class, maybe, if even. Again, all the complicated details aren't important, but throughout this lecture and kind of one of, knowledge being power, you can advocate for yourself with your doctor if you know what you're talking about. So the main thing to go through is, if you're looking at your menstrual cycle, you've got 2 main hormones. That first half of the menstrual cycle is going to be estrogen dominant. There still is a little progesterone though. And then you ovulate, and the second half of your cycle is progesterone dominant. But you have progesterone and estrogen throughout. It's the fluctuations in these hormones that cause symptoms. And as we get older and the egg quality decreases, the amount of progesterone starts to decrease. And that's when we're hitting perimenopause and we start to feel symptoms. So this might be helpful just for you to think there's progesterone and estrogen throughout, but they do go through cycles. They balance each other out, and they're dominant in different phases of the menstrual cycle. So I like to think of progesterone, and I often hear them described as estrogen is the gas and progesterone is the brakes. They really work together in tandem. They have a symbiotic relationship. And so it's important that they stay in balance. And progesterone has effects throughout the body. Again, I bring this up because it's important. It's not just the uterus. It also has effects on the GABA receptors in the brain. So that's what makes us feel calm. It's what makes us sleep well. It keeps in control anxiety. It has, receptors throughout the body. It's actually considered neuroprotective. And in Europe, it's being used for traumatic brain injuries, for stroke patients. So this is the first hormone that we really consider replacing for women who are in perimenopause, because this is what starts to go down. Estrogen is the gas. I won't get again into all the nitty gritty, but it has effects throughout the body, not just, in the way we would typically think of female hormones. There's 3 different types, E1, E2, and E3. You can start to have fluctuations of estrogen in perimenopause. It really bottoms out in menopause. And once these levels change, that's when you start to get hot flashes and some of what we call the vasomotor symptoms. I put a little picture of the liver here to remind me to say that before we can even consider replacing this, we need to make sure you're detoxing it well, because there's good estrogen and bad estrogen. And you want to make sure that your body is really primed to get rid of the bad, use the good properly, and that it's not sticking around just because you're not detoxing well. So now getting into what's actually going to happen to my body during perimenopause, because that's what we really care about. Widely variable, and some people may not ever have symptoms. A lot of the things that I hear are starting to be irregularities in periods, very heavy periods, spotting, it's light. I used to be regular every month, and now I'm irregular, skipping periods. Those are all kind of pretty normal symptoms that would drive someone to their doctor. In addition to that, the mood part is really important. And this is what Oprah was talking about, so I'll bring it up again. depression, anxiety, insomnia, irritability, libido changes, decreased sex drive. And then this you won't notice, but this is when bone density does start to decrease. So this definitely isn't a comprehensive list. These are the most common. But Oprah had mentioned she had palpitations. I think the most important thing I could say is that when you're in this phase, or you think that you might be, and you are noticing a shift, like maybe you always were anxious, but now it's keeping you up at night and you're not sleeping. You're waking up multiple times a night. You're not excited or able to get interested in things like you used to. A little bit of brain fog, difficulty concentrating. These are all worthwhile to bring up to your doctor. Some people do get some of those vasomotor temperature symptoms here, but those tend to happen a little bit later. And menopause. So what is the definition of menopause? Technically, menopause is 1 year without menstruation. Does that mean that I make patients wait an entire year? Okay, so it's been 11 months. You've got to wait another month before you've had a period to start replacing hormones. Definitely not. And the reason for this is you're going to have symptoms before it's been a year. And, the main FDA approved reason for using HRT is to decrease symptoms. So this is really important. We absolutely do not wait until it's been a year, but that's the technical medical definition. What is also happening behind the scenes, you're getting symptomatic, but what else is happening? You're starting to become at risk for heart disease. Estrogen is cardioprotective. So without that estrogen, you're becoming more at risk for things like heart attack and stroke. Bone density is decreasing. So whatever your baseline bone density was, if you've had a DEXA scan, you're now becoming, your bone is becoming less dense. It's becoming more osteopenic. And you're at higher risk for dementia at this time. So this is kind of my first place where I just want to make a little plug. I think, that looking at all the different options available for treatment, hormone and non-hormonal, is important. But I do want to, and I hope that the thinking about HRT shifts a little from I'm just treating symptoms to actual preventative medicine, because for the right patient with the right medical history, it does a lot more than make you feel better. It actually prevents chronic conditions in the future. Okay, so before we can dive into what are your options, what's covered by insurance, what's not, for actually replacing hormones, testing, super, super important. One of the things that I benefit from working at SeeBeyond is I have access to a ton of testing beyond just what a conventional provider might be able to order. So I'll tell you kind of what you need at a minimum, and then in my perfect ideal medical functional medicine utopia would look like. For all treatments that you do, you really need to first look at what your baseline is, and not just of your hormones. Again, I'm going to say it again. Don't forget the gals, your gut, adrenals, liver, and sugar. So make sure that all those systems are optimized and ready to go before you even consider replacing hormones. And then we test. So blood tests, that's covered by insurance. Any provider can do that. We look at all your hormone levels, progesterones, your estrogens, your testosterones, among other things. And then in my ideal world, I would also get something called the Dutch test. And this is a urine test that looks at both the adrenals and your hormones and their metabolites. So what that means is it gives a really good glimpse into what's going on in your body. Not only how many hormones or what quantity of hormones do you have at your tissues? Are they starting to go down? Are you really far on the menopause train or perimenopause train, or are you just starting out? Do you need progesterone alone? Do you need progesterone, estrogen, and testosterone? It also tells us how are you metabolizing those hormones. So this, I don't expect anyone to totally understand, but if you've had a Dutch test before, this is what the results look like. If it looks complicated, that's because it is complicated, but I love it. On the one side, on the grayed out side, you start to see with a little pie chart, those are the estrogens, your androgens, your progesterone. So it tells us what is your absolute level, what's going on at the tissue, and then how is your body excreting it? Are you detoxing well? Is your liver working well? And then on the right-hand side, that little like kidney shaped thing, that's your adrenals. I heard while I was researching all of this, I heard a doctor refer to the adrenal glands as your 401k. So the ovaries are retiring. They're going out of business, but you need your 401k to live off of. And that's what your adrenals are. They are what's going to support you when your ovaries are producing less hormones. And I bring that up even for younger women who aren't in perimenopause yet, or who are in perimenopause but not in menopause yet. It's never too soon to start getting your adrenals in working order. It helps with your resilience, it helps with your hormone balance. And when it does come time for hormone replacement therapy, if that's something you want to consider, you're just going to optimize how your whole body feels. So blood test, urine test, if you're willing to go that extra mile. Once you start hormone replacement therapy, again, it should be very personalized to you and your lab values. So you should test before you start and then test after you start to see if it has to be tweaked at all. Okay, so what is the treatment for menopause or these changes in hormones? Personalized, we call BHRT, bioidentical hormones. That term seems a little confusing to me because what does that mean? Is it coming from a human? So a bioidentical hormone is a hormone that is made in a lab. So it is actually made in a lab, but it is made to mimic our own molecular structure. This is not the hormones that were being used in that study 20 years ago. Those were synthetic. These are different. They mimic our internal structure. They are plant derived, usually from yams or soy. They are an exact match to the hormones that are occurring in their body. And there are both compounded and commercial products available. So even those commercial products made by Big Pharma, those are bioidentical hormones for the most part. So lots of options. I put a little star next to FDA approved for symptom management because in medicine, especially in integrative or alternative medicine, there are things that are FDA approved and we use them often off label. What hormone replacement therapy right now is approved for is to manage symptoms. So if you have hot flashes or night sweats, that's what it's approved for. What it is used for in practice is way more than that. We're protecting your heart, we're protecting your brain, we're protecting your bones. The decrease in symptoms is also very nice. We're improving your quality of life. The reason why that has not been approved by the FDA for those specific purposes is not because it's unsafe. It is because there are not sufficient studies yet to prove that if you give hormone replacement, you will decrease heart disease by X, Y, and Z. Until we get those numbers, they can't approve it for that purpose. I think that's important to know. It's not because it's unsafe. I also think that's important to know because it highlights that women's health has traditionally been understudied and underfunded by pharmaceutical companies. So the data is not there yet because there haven't been a lot of studies on women. It just hasn't been on the forefront. It amazes me because there are lots of studies in pharmaceuticals that help with erectile dysfunction and other things, which is also a natural decline in hormones with time. But women's hormones has really not had a spotlight on it in a while. So again, all the more reason why it's super important that you be knowledgeable and find a provider who can work with you and can interpret the studies properly. Okay. Did I go over this? So progesterone replacement, there are creams, there are pills. I prefer orally if you're just doing progesterone because again, it has effects on the brain, the breast, and the uterus. Estrogens, again, there are patches, there are creams, there are pellets, and testosterone replacement, which is for the right patient. Again, there are creams, there are pellets, there are injections. It's very confusing. There are a lot of options, and it's important that all of them are presented to you. In perimenopause, usually this is where we start to replace progesterone. And that's when people are getting insomnia, irritability, other symptoms. They go on progesterone and they're like, oh my God, I'm finally sleeping. I just don't want people to wait until they've had a year or two of bad sleep. So starting at a very basic level, you can start with just a supplement to kind of regulate your menstrual cycle. And that would be something like Vitex if you wanted to go very minimal. And then beyond that, we go straight to progesterone replacement. Again, lots of options. It can be confusing. There are the oral micronized bioidentical progesterone. That's what helps the most with anxiety and insomnia. And I know, at least for me, sleep is so important. Not feeling anxious day to day is so important. So a lot of women do come to us for that. If you don't feel like you have anxiety or insomnia, you could do the cream. Some patients do have some side effects with fluid retention if that bothers you. I think now there's actually a progesterone coated IUD. So my point is, I think oral is best, but you have lots of options. So again, progesterone therapy improves sleep. It does decrease some of the hot flashes. It starts to improve bone density, it protects your heart. It's been shown to be really effective with menstrual migraines, which a lot of women may never have had. And then they hit perimenopause and they start getting worse PMS, worse periods. You're like, I thought I went through this in my teenage years, and now I'm suddenly having these horrible periods. So progesterone can really help with that. And should not, and it also helps balance out estrogen. So estrogen, again, is the gas. It causes a thickening of the uterine lining. So it's good to have progesterone on board to help it from over proliferating, if that makes sense. If you're still having a period, we would typically cycle it. So you take progesterone the second half of your cycle, day like 12-ish to 28 in a 28-day cycle. You're menopausal, you would take it throughout, or if you just find it's really helping you with your sleep and anxiety, you can take it throughout as well. Okay. Estrogen replacement. Again, so many different types, and it depends on what symptoms we're treating. So creams, I really like, because compounding pharmacies can put 2 of the different types of estrogen in one cream. It's called Biest. Pellets we use a lot at SeeBeyond also, combined with testosterone. And I'll go into a little more explanation of what each of these things are. The patch is very popular. It's a bioidentical hormone by major pharmaceutical companies, covered by insurance. So that's a great option. Totally personal preference. They all have pros and cons. And, even for patients who do have a personal history of breast cancer, there are, vaginal suppositories that have been shown to be safe. So there are options. There are options for everyone. Okay, a couple of graphics just to, again, kind of bring home that there are options. It can get confusing, but if you just have a provider who will walk you through each one, and you can say, cream's not for me, I want a patch, or I don't want a patch, I want a pellet, it really is personal preference and your history. So here we see a patch. You put on a patch usually twice a week. Sometimes if you're starting early in perimenopause, you can even just cut it in half. There's vaginal suppositories, which are really helpful for some of the other symptoms of menopause that occur with the decrease in estrogen, which is often called vaginal dryness. It's not actually dryness, it's inelasticity. So your skin has less elasticity, less collagen, because you don't have that wonderful estrogen around anymore. It can make sex really painful, can make you more prone to UTIs. It can give you, irritability when you pee along your urethra. So intravaginal estrogen can really help with that too. So it really depends on what kind of symptoms you're looking to treat. The patch and the creams are really good for those hot flashes and night sweats that can be really a nuisance. Okay. Creams and compounding pharmacies. This has its own slide because depending on which provider you talk to, we use compounding pharmacies all the time at SeeBeyond. We have the wonderful benefit of having some local ones like Westchester Compounding and Rye Beach Pharmacy that are highly reputable, and that we trust and work with all the time. But they can be controversial. And the reason is that some doctors and providers feel there's not enough regulatory oversight. So all the materials compounding pharmacies use to make their bioidentical creams are FDA approved, but the final product doesn't go through another level of scrutiny, if that makes sense. So the raw materials, FDA approved, but there's very limited regulatory oversight, and most compounders don't have to report adverse events. This is super technical, but if you're really like a by the books kind of girl, then maybe the big pharmaceutical route is right for you. The reason why I like compounding pharmacies is because I get to do all this testing before. I've gotten your urine, I've gotten your lab work, I see where all your levels are at, and they make a compounded cream that's going to have the 2 types of estrogen in it, the progesterone in it, testosterone in it. And we can tailor that to your needs, what kind of symptoms you're having. And when we recheck your levels, say we're like, oh, your estrogen's good, your progesterone's still a little low, we can just increase the progesterone. So it's very personalized, very customized for each patient. We have starting doses that we like to work with, but we can really tailor it from there. So that's one great benefit of these compounded creams. The downside is some people, you have to put it on in a place where your clothes are going to cover so no one touches it. You have to rub it in for 5 minutes. Some people just don't like it. They find it messy. Again, that's personal preference. Okay, what is a pellet? So pellets are not done everywhere. You will find mostly like integrative medicine providers that do offer pellets as an option. Patients ask me all the time, like, what is a pellet? Like, what are you even putting in me? And so when you see that hand there, I would say that's probably true to size. That looks like one testosterone pellet and one estrogen pellet to me. And what a pellet is they are, again, bioidentical hormones. We usually get them from a compounded pharmacy. And we take, you see that little technical diagram of the different layers of the skin. We numb your skin kind of in the upper outer butt area where you've got a little cushion, numb you so you don't feel anything. And then we stick that little metal trocar in, make a little passageway into the fat. And then we put these teeny little rice, smaller than the size of a grain of rice, under the skin. It allows for a slow release of hormones, usually lasts patients anywhere from 3 to 6 months, and they don't have to worry about creams or pills or patches. So for that reason, it's kind of like a set it and forget it situation. So patients like that a lot. It's a nice fat, actually, these types of hormones like fat. So the fat kind of serves as a hormone reservoir for a more controlled release. So again, that's one option. Those are the pros. I think the pros are you don't have to worry about it. It's slow release, very little side effects, minimally invasive. We do it with testosterone and estrogen, and then you take the oral progesterone. The cons would be, the benefit is it lasts 3 to 6 months. The con is that it lasts 3 to 6 months. So if the levels are too high, there's nothing we can really do but to kind of wait for them to go down. Which is why I kind of put down the start low and go slow philosophy. Can be frustrating at first if you're like, because you feel so good after you get these hormones. Patients report very quickly, their brain fog goes away, their energy goes up, they can build more skeletal muscle, libido goes up, vaginal lubrication goes up. And we know the benefits to the brain and the bone as well, and the heart, but we do have to start at a low dose because you're kind of stuck at whatever you get. And eventually we get to the dose that works best for you, and then you're kind of cruising. Okay, I don't go into this a ton, but we do deal with it a lot. And I just wanted to stick the slide in because there are patients who, for the most part, the only true contraindication to getting hormone replacement therapy is if you personally have had breast cancer. If you have a strong family history, it's something to consider and talk to your provider about. It does not mean you can't get hormones. It may mean you decide not to. You don't want to take the risk. That's fine too. Again, it should be a conversation. But if you cannot do HRT because you've had, estrogen sensitive breast cancer or some other condition where it's just not a good idea, you are not doomed. I know I'm like kind of touting all the benefits of hormone replacement therapy, but there are other things we could do. And sometimes it's not even because you've had a medical condition. I have a lot of patients who are like, I don't want to, my hormones are supposed to go down. I don't want to feel these symptoms, but I also don't want to take hormones. That's fine too. It's not, no one should convince you into anything. So this is just kind of an example. Black cohosh, for example, is thought to be equivalent to the very lowest dose of an estrogen patch as far as how it helps with symptoms, those vasomotor symptoms, the night sweats, the hot flashes, the difficulty sleeping. So, there are targeted diets, there's specific exercises that you can do at certain parts of your cycle. There's estriol, which is a vaginal suppository of a type of very weak estrogen that can be inserted even for breast cancer patients that really helps to make sex less painful. And will not increase your risk of having, further cancers. So my point is, there are options. I can always go into it with people, offline. What can I do naturally to decrease my symptoms and still protect my health in the future? So now we've kind of gone through the definitions of what perimenopause is, what menopause is, what are the symptoms, why do I like HRT for the right patient, what are we protecting here? And the importance of finding a provider who's going to walk you through these options. And they really need to, and you need to, it needs to be a team effort, weigh the risks and benefits. Again, I don't think there are a ton of risks. That's my personal opinion. The benefits to me outweigh the risks. They're huge, protecting bone mineral density, relief of your menopause symptoms, which don't ever let anyone make you feel like, oh, it's just some hot flashes. If it affects your quality of life and your daily life, then it's important. Cardiovascular health and cognition, preventing dementia. Those are big ones. What are the risks? Endometrial cancer, anytime you give hormones, is always a risk. Breast cancer, I'll go through the exact numbers. It's very low risk for someone who doesn't have a personal history of it. So those are the main things there. Osteoporosis, so bone health. I don't want to beat a dead horse here, but I just do want to make sure. This seems like for a lot of us, this is so way far in the future. Why am I worrying about breaking a hip? And the reason why I worry about myself breaking a hip when I'm older is that the mortality rate for women after a hip fracture, after the age of 65, within those first 3 months of breaking their hip, their mortality rate goes through the roof. It's something like 5x. So I'm using that as kind of an example of the health things that can happen that you can deal with now in your 30s, 40s, 50s, 60s, so that you don't have an event happen later on that's going to decrease your lifespan or decrease your quality of life. Prevention is key, and estrogen is incredibly important for bone density, for that bone turnover. So that is one of the reasons why I really like to consider hormone replacement therapy. And heart disease. There is a reason why men start to have heart attacks before women, and that is because they don't have estrogen. For as long as we have estrogen pumping in our bodies, it protects our heart. It keeps that LDL, that bad cholesterol number, down. So estrogen, not needing to know all of the details, but it's a vasoactive hormone. It works on the vessels. That's why when those levels go down, your vessels go crazy and you get the hot flashes, the night sweats, all of those vasoactive symptoms. They're uncomfortable, but also kind of should signal to you what else is going on in my body. Your vessels are being affected. You can start to build up more plaque. You can start to develop more risk factors for cardiovascular disease. So replacing estrogen, we do think protects the heart. The latest studies have shown there really is a timing hypothesis to this, meaning if you're already 10 years into menopause, you're probably not going to get much benefit from it, from what we can tell. So the earlier you start it, within the first 10 years of menopause, there has been shown to be a significant risk reduction for heart disease in the future. So you really have to go, but you have time within 10 years. That's a big window, with earlier being better. And if you might be asking like, all right, well, I do want to protect my bones and my heart and my brain, but I don't have any symptoms of menopause. Why would I put something in my body? You don't have to, but if you want to, you could just go on a very low dose. 0.1%. I put this kind of in big because I think that even despite everything I've said and despite all the research that's going on right now, there still is a lot of fear related to that study 20 years ago that if I go on hormone replacement therapy, I'm going to get breast cancer. And then how could I, deal with that? So these are the actual numbers. There's 0.1% absolute risk and increase in breast cancer if you're on HRT, 0.1% for someone with regular risk. It is very minimal compared to what will happen, which is your bone density will go down and you will be at greater risk for heart disease. So it's just part of weighing those risks and benefits. And then, I also we're talking about such big things with the brain and the bone, and your heart health, but I don't want to minimize just the day-to-day symptoms of what people go through in perimenopause and menopause. Sleep disturbances are a big deal. Anxiety is a really big deal. Night sweats, hot flashes that keep you from functioning at your job, interacting with your friends and family, sleeping. Again, you can tell I'm a little sleep obsessed. I think sleep is just the cornerstone of health and happiness. So all of these things are really important. And, I think it's not something we should have to muscle through. If you want to, that's fine, but bring up a conversation with your provider. If they're not bringing it up with you, that's a shame, but don't try and muscle through things, because this isn't, 1 or 2 months. This can be years of your life. And it's worth it to be able to think clearly, to feel good, to prevent heart disease, to sleep well, to feel happy. Like, these are all really important things. They're not small issues. I take them very seriously. So, if I can impress kind of one thing on you, I know that was a lot of information, kind of a science nerd. So it's a lot of details about hormones and what they do and what your symptoms are, and the treatment options can be overwhelming. But the most important thing is to find someone who's going to have a conversation with you. It should be between you and your provider working together to come up with the right option for you. And that is pretty much it on my end. The only thing I realized I didn't focus on is what's covered by insurance and what's not. For the most part, anything compounded is not covered by insurance. Pellets not covered by insurance. Patches are covered by insurance. Most of the vaginal suppositories are covered by insurance. Progesterone pills are covered by insurance. I think I covered it there. So now if you have any questions, feel free to, see it here in the chat. Sorry, I'm not the best with Zoom, but okay. First question: how do the injected skin pellets compare to low dose birth control pills? What levels of hormones are in each? That's a great question. So they are higher doses, but birth control pills are targeted doses to kind of trick a typical birth control pill, I should say, is estrogen, progesterone, that are in dosages that trick your body into not ovulating. It's specifically so you don't ovulate and you don't get pregnant. What we are giving with hormone replacement therapy is a totally different formulation. It's not made to prevent pregnancy. And so how does it compare to those? It would be hard for me to compare dose for dose. I believe what we would give in a pellet is a higher dose. Usually we start with like 12.5 milligrams. What we're trying to mimic is what would naturally be in your body during a fertile time period. And the progesterone you would take orally we usually start at 100 milligrams. So I hope that answers your questions. They're totally different formulations, even though we call them all estrogen and progesterones. They're really pretty different. One's bioidentical hormones that are meant to mimic your natural menstrual cycle. The others are meant to trick your body into thinking you have enough. They're not bioidentical, and they suppress your own ovulation. So they really shouldn't be used interchangeably. Okay, next question. If 2 years into menopause and had light symptoms, what benefit do you believe I would experience, assuming not too late to start? 100% not too late to start. That would be a definite worthwhile conversation to have, just to know what your risk factors are, what your family history is of all of these things, of cancer, of your family's cardiovascular, your personal cardiovascular, what's your cholesterol like. So a lot that kind of goes into that, but all the studies really show that as long as you start hormone replacement in the first 10 years of menopause, you can really get the bone and heart benefits from it. Light symptoms. So sounds like they're not totally disrupting your life, so you wouldn't have to take them for that, but even just a low dose of estrogen and progesterone to protect your bones and brain and heart, I think would be worthwhile if that's something that you're interested in, especially if you have a lot of heart disease or risk factors in your family. But 2 years is not too late. I mean, it's never too late, but within 2 years is like a great time to start. And again, you would weigh the risks and benefits. If you don't have a lot of symptoms and you may not want to start it, that's fine too. I did a Dutch test, and I'm reading the questions out loud just in case everyone's not reading it. I did a Dutch test and my provider expected my progesterone to be low or declining, and it isn't. What is low is testosterone. Is HRT appropriate, or can I get my testosterone up another way? Awesome question. This is why I love the Dutch test, because it's not always what you expect. Testosterone, we always think of as a male hormone, but it's super important for women to maintain their skeletal muscle, which also prevents breaks in the future. And libido, energy, it affects so many things through the body. So I don't want to forget about our friend testosterone. Are there ways to get it up naturally? Absolutely. So first, and HRT would also be appropriate. So a two-part kind of answer there. What I usually start with in women is, just because I am a functional medicine provider, I always try and go the most natural route first. And I've had a lot of success with women in that. I would increase your strength training. So like 70% of your exercising should be like serious weights, not like don't kill yourself, but get a trainer, do 1 or 2 sessions so you have good form, and then really like hit the gym. That will boost your testosterone as well. And then there's a supplement called DHEA. For women, the dose is around 5 milligrams to 10 milligrams. That's a precursor to testosterone and estrogen. So as long as you're detoxing well, which they can see on your Dutch test, DHEA is a great natural way to raise your testosterone without actually giving testosterone. It helps with energy, libido, and again, skeletal muscle. So I've had great success with that. DHEA works far better in women than in men. So that's awesome. And it's something that I use for my patients a lot. If none of that works and your levels are still pretty low, you would absolutely be a candidate for testosterone replacement. And again, that could be done through a cream, a pellet, or an injection. Just confirming, insurance will pay for the compounded bioidentical, but SeeBeyond would be private pay. Correct. Insurance doesn't always pay for the compounded. That would be insurance dependent. And usually you can call the compounding pharmacy. They're very knowledgeable. I've had really wonderful experiences talking with the pharmacists at compounding pharmacies. So it's not always covered by insurance. I mean, we don't take insurance at SeeBeyond, but we are not the only ones who can, prescribe bioidentical hormones. Regular OBGYNs who are knowledgeable on the subject do as well. So I would ask your local compounding pharmacy what their experience has been getting these creams covered. Cycle is every 28 days. I'm 49 years old. Okay, I think that was just a follow-up. Okay, so 49, you're still having a regular cycle, 28 days. Yeah, so I mean, I would love to hear more, Christine, about your case, but I think at least treating the testosterone replacement would be worthwhile. If the progesterone's not low, I wouldn't replace it. This is why women's health is so interesting and important, but everyone is so different, and all your different factors need to be taken into account. Okay, if I'm not having real symptoms except weight can't get rid of 50. Okay, I didn't bring up weight. I really wanted to bring that up. Thank you, Denise, for reminding me. So weight is another big one where people are like, oh, I've got like 5 or 10 pounds and I'm like eating healthy and exercising, doing all these things, and it just won't come off. That is a lot of what drives patients into the office. That is a symptom too. That is, hormone shifts will cause you to put on weight in different areas or to hold on to weight. That picture I showed in the beginning that showed all the different arrows to your brain, to your gut, to your liver, that is important because all these hormones affect things throughout your body. Like the thyroid affects your metabolism, like the thermostat for your metabolism through your body. So during perimenopause and menopause, it's not just your female hormones that are changing. There can be shifts all around. First, you should have other lab work done, check your thyroid as well. But oftentimes when women do go on hormone replacement therapy, they have better luck like losing that weight that they felt like it keeps going on or isn't coming off. So that would be one, worthwhile reason to discuss with your provider, possibly going on HRT. What is the best way to set up an appointment with me? I work at SeeBeyond Medicine in Scarsdale. We see patients both in Scarsdale. I also go to their Greenwich office, which is new, and I live closer to there, so I always welcome seeing patients there. And I also do telehealth. So, if you're new to SeeBeyond or functional medicine and you want to know kind of more of what we're about, we do, with some of our nurses and health coaches, free consults just to see if it is a right fit for you. If you just want to talk to me, and I also work with Dr. Lee and Dr. Dahmer, who, one of the things I do love about working at SeeBeyond is that I have access to everything. So like I can do everything from a pellet to a cream to a patch, and it doesn't matter to me, but it does matter to me that my patient feels like this is the right choice for them and that they've been heard and they've been able to express their history and what their concerns are and what their goals are. And that we make that right choice. And then if the pellet's what they want to go with, I'm able to do that here. If a cream's what they want to go with, I'm able to send that into a pharmacy. So that's been really, wonderful as a provider just to have so many options available to my patients. Does SeeBeyond have regular gyno doctors so I can move on my family? We don't, Dr. Lee and I do pap smears, and we're set up to do GYN exams. And we've all been trained in them. We've been doing it a long time. I've been doing pelvic GYN exams since the beginning of my career. But we definitely don't take the place of seeing an OB/GYN. We can send off a pap smear. That brings me to one more point before you all leave. The other thing, if you're nervous, or even if you're not, about breast cancer, if I haven't convinced you that that for most people, it's not risky to go on HRT, I still adamantly insist that people are up to date on their mammograms and their DEXA scans, because those are screening tools that are there for a reason, and will catch things. And it's just an added layer of security. So all of those things, although I'm functional integrative medicine, I still really believe in all the safeguards that we have in Western medicine. I hope that answered all of your questions. I'm super passionate about this, so I could ramble on and on forever. It's a lot to cover, and I can always go over things in more detail if there's need in the future. But I really appreciate you all listening. And I think that's it. All right, I'm going to slowly wrap this up. It feels weird to not be directly dialoguing with people, but again, I appreciate you tuning in. If you only got to see part of this, or there are things I missed, I'm sure, and you wanted me to go in more, I think this information will be available on our YouTube station, or I think you call it a station, and I'm always available to talk more. The best way to set up an appointment with me is just to call SeeBeyond and let them know and they'll set up an initial. I usually ask for an hour to do an initial exam because we have a lot to get through. I want to hear about your goals, your childhood, your family history, your stomach, how you digest, more questions you could than you probably want to answer, but it's all relevant and important, and how we get you feeling your best. So yeah, you can just call our front desk, and if telehealth's best, if Greenwich location, Scarsdale location, I can do any and all of the above. All right, guys, I hope everyone has a great rest of your day, can enjoy a little of the sunshine, and hopefully I'll talk to some of you again soon.